Our first speaker is Dr. Gailen Marshall, who will enable us to level set for the day with an overview of prevalence data, current guidelines, and the college's goals for the next year. Dr. Marshall is the chair of Allergy and Immunology, professor of medicine and pediatrics, vice chair for research, director of the Division of Clinical Immunology and Allergy, and chief of the Laboratory of Behavioral Immunology Research at the University of Mississippi Medical Center in Jackson, Mississippi. His clinical interests include improving clinical control and quality of life in underserved minority asthma patients. Dr. Marshall has published over 200 peer-reviewed articles, reviews, editorials, and book chapters. He currently serves as the president of the college. Please join me in welcoming Dr. Marshall.
It's a great pleasure to be here with you this morning. And on behalf of the American College of Allergy, Asthma, and Immunology, we are delighted in our continuing partnership with the AAN and the work that they do. And each one of you, as you represent, this is a class organization. Be engaged with them, learn from them, and then give them feedback, because they actually do listen to what you have to say. Not everybody does, but they do. What we want to talk today about are some of the current challenges. I've been doing this for a fair amount of time, coming up on about 40 years. And the way we take care of asthma patients now has so many more opportunities than they did when I was a junior faculty member 40 years ago, but interestingly, some of the outcomes stubbornly have not changed that much. And I want to discuss that with us a little bit and talk about some of the opportunities to make changes that would involve you both as participants as well as potentially recipients. The current concerns we have, again, asthma can still be life-threatening. When I started, they tracked that there was probably about 5,000 to 7,000 deaths a year in the United States from asthma. As I'll show you in a second, they've got that number down, but that number ought to be like 4. And it's not. And so there's still a lot of work to do as it relates to that. But even though it may not be life-threatening, and in some instances, unfortunately, healthcare providers or even the public itself, if they either don't know people that live with asthma or they themselves don't care of asthma, they trivialize the illness as being, well, nobody really dies of asthma, so why should we spend a lot of money to take care of them? And I think that organizations like the AAN has done a wonderful job in keeping that before the public, whether it is the payers that have insurance, whether it is the legislators that make rules, or whether it's other healthcare professionals that come to learn that asthma is an important illness and it has tremendous impact on our population. Hence the delight, again, that the college has in partnering with this organization. Even when it's not life-threatening, it has a profound effect on patients' daily lives. Environmental challenges are a big thing. You're going to hear some really interesting information about climate change. So the interesting thing is it's a sad but an amazing thing how sometimes science and medicine gets pulled into politics, just I guess like everything else. But then they argue about it. Well, climate change is not happening. Climate change is happening. It's because of cars, so we need electric cars. It's not because of cars, all that stuff. Well, let me just give you a little tip. If you believe in data, climate change is real. The argument is the why, okay? But it's irrelevant why, because if the patient can't breathe good quality air and she or he has to suffer it, it doesn't really matter why. It's the what that matters. Climate change has occurred. The same thing is that pollution is worse. You can measure it. It is worse. Now, is it our fault? Is it not our fault? Is it the cycle of the earth that's going to make it go away in 100 years and all that? I don't know. And I think that a lot of people that prognosticate don't know either. The fact is, pollution is here. The fact is, it's more crowded now. Even where I come from in Jackson, Mississippi, who don't have rush hours, we have rush minutes. The rush minutes are getting longer. We're almost on our way up to a full rush hour. But when I moved there 20 years ago, it was like a rush 15 minutes. So it's getting more congested. Urban areas are getting more congested. wildfires have a lot of impact. And one of the impact is how they change the environment. And they don't change the environment for a week. They change the environment for years, and sometimes even more. Indoor air quality, we used to talk about that a lot. We stopped talking about it a lot, and it particularly adversely affects individuals in certain underserved populations because they can't buy the fancy air filters, because they can't afford air conditioning that processes this air in a way that improves the quality of the air. These are all real concerns. And as we become more diverse, here's the interesting thing. Everybody wants to promote diversity, equity, and inclusiveness. Unfortunately, asthma is the poster child for diversity, equity, and inclusiveness. It doesn't care about your race, it doesn't care about your age, it doesn't care about your gender, it doesn't care about your socioeconomic status. It's coming after you. And the fact is, recognizing that helps us band together and say, we need solutions that are common in mechanisms but have specific applications depending upon who it is that we're giving it to. I need a vehicle to get from point A to point B, but I don't necessarily need the most expensive vehicle, or I don't necessarily mean the fanciest vehicle. You match my vehicle to my need, but the fact is that I need it. I tell patients all the time, when you're born, you get two things. You get an owner's manual and you get a pencil. No one, I'm sorry, I don't mean to ignore you guys. I realize you're over there, I'm sorry. I'm old, it's okay, I get tunnel vision. You get an owner's manual and you get a pencil. No one ever reads the owner's manual cover to cover, and everybody takes the pencil. Some start early in the early chapters, others wait a while, and they start marking things out and writing them in. And by that silly analogy, the owner's manual is what makes us all human, and the pencil is what makes us individuals. And the key for working with asthma, like any other chronic illness, is to keep both of those aspects in mind. What can I offer that would fit for all asthma patients, and then how would I use it that would fit for Ms. Jones and Mr. Smith that would make a difference in the context of that? That's the trick, and that's very much an important thing. Things like RSV in adults, it's been around for kids for a long time. COVID-19, the pandemic, had a real impact. And the future viral pandemics, it's not are they coming, it's when are they coming? Are we going to be prepared, and are our patients that have respiratory illnesses like asthma going to be properly prepared to contribute to prevention or at least management of these long and persistent symptoms? The economic realities, yeah, the good news is that we have new fancy medicines. The bad news is that nobody can afford them. So what you've got is a whole new area of science that is emerging called implementation science. And the argument is that we've gone to all these efforts to develop, and I've been involved in many of these studies over the years, and it says it can work. That's what the word efficacy means. And then the challenge is how to get it into the community, whether it's a device that can't be used like simply, whether it's access to something that most people can inject, but it's $45,000 a year, whatever it is, how to implement that so it can be utilized. That's a new area of science that is intensively engaged, asthma being one of the major targets. The economic realities are pressure, and that pressure is not going to go away anytime soon. Recommended care based on national guidelines, again, because of the way our healthcare system is organized, insurance is by the state. If I live to be 100, which is not that far away, if I live to be 100, I'll never understand that logic. Why is it that if I live in Mississippi, I can't buy insurance that is marketed by somebody from Delaware? It makes no sense to me. But it's still a problem, and I will tell you one of the things that I would suggest, not just for asthma, but particularly for asthma, is as we move forward in our political system, look for and support legislators who want to find a better way with health insurance to offer it. Because I don't know about you, but when I shop around and somebody knows that I could buy theirs, or I could buy theirs, or I could buy theirs, they're going to be more reasonable in offering me a reasonable price than if they say, I'm the only show in town, take it or leave it. And that's kind of where we are in healthcare insurance right now. And unfortunately, that really applies in things like asthma. 25 million currently that are diagnosed with asthma. 1 in 11 U.S. school kids that have asthma, $82 billion in annual healthcare costs, and the projectionists say that this number will triple in the next 10 years. Triple in the next 10 years. 3,500 deaths. Again, it was about 5,000 when I was first starting out. And so, yeah, we've decreased the number a nice percentage, but that's still 3,513 too many. And I figure the 4 that die are because they ran out in front of a bus and they had asthma, not because that they die of asthma itself. And I'm not saying that in any way to be cheeky. 13.8 million school days kids need to be in school to learn. 10.9 million work days that cost a tremendous amount of money. 3 in 5 individuals with asthma are limited in their physical activity. We do this regularly every time every asthma patient comes into our clinic. We reinforce proper inhaler technique because 70% of the people do not use it correctly. And even if you reinforce it, they still don't learn how to do it. And then, of course, insurance swoops in, changes the inhaler every year, and you get to start over again. So all these things are issues that make a tremendous difference because it does no good to have really great asthma medicine that gets in your mouth and gets swallowed. It's got to get down in your lungs in order for it to really work correctly. And it costs about average almost $3,300 a year to take care of everybody with asthma. Do the math times 25 million and you get an idea of where these costs come from. The biggest thing I think that has changed for me over the years is we used to think of asthma. When I went to medical school, there was 2 kinds of lung disease that was obstructive. There was asthma and there was COPD. And asthma was over here completely reversible and COPD was here completely irreversible. And everybody that had asthma, we knew why. Well, it turns out that there are a lot of different reasons for asthma to have this reversible airway obstruction. There are a lot of reasons for having COPD that has irreversible airway obstructions, and they are not, sorry about that, they are not silos, they're a continuum. That is the biggest thing we've learned, and what that's done is modified how we view asthma and how we treat it. Identifying the phenotypes, what that patient presents as well as the endotype, the mechanism that it's creating. It's an allergic one with lots of allergy antibody, lots of eosinophils. It's a non-allergic one with very few eosinophils and not really any allergy. They both have obstructive disease, but not surprisingly, they don't respond the same way to the same medicines. That's a fairly recent acknowledgement and recommendation, and that it's not just 2 now, it's probably 20 when you really get down to it. And the question then is, when do you parse it too much? Because will number 2 and 7 and 11 and 13 respond to the same regimen? That's a very active area of research right now and trying to understand that. Treatment innovations like novel targeted therapies, they're all developed there. Again, the problem is, again, when we develop these novel therapies, are they really going to make a difference? And of course, it costs a lot of money to develop these therapies. We live in a capitalistic society. Nobody in this room doesn't cash their check. We all live in a capitalistic society, so how do we do this in a cost-effective way that does not deny access to individuals who really need it? That's a conundrum that is at not only the government level, but it's in the advocacy level like we're here today. It's in the medical and the scientific level. It's all the way across the board. And developing biologics and other small molecules is the wave of the future, but it's not there just for its sake. It is as we learn better how to treat this person's asthma and that person's asthma, can we use the same thing, or do we have to use different ones? Other innovations, increased recognition of differences. Well, we've for a long time known racial differences, but the reason was why. The question is, all right, so asthma as a group, all things being equal, is more severe and has worse outcomes, and it's more expensive in underserved minority communities, particularly in the African American community. Is it because they're African American? Is it because they're poor? Is it because they're discriminated against? How about the answer is yes. It's yes to all of those. But on the other hand, what about, say, for example, Appalachian populations where they're very the same except for their race? Is there a difference? Well, there is a difference. Understanding this information becomes very important, and it goes back to the thing that we talked about at the very beginning. We're all in this together. And if we're looking at it together and not looking for all the differences, but we're looking for the similarities and the commonalities, that starts with the respect for the individual person, I think we'll ultimately be successful at this as we work our way down to the genetic level. I'm trained as a basic scientist who went to medical school, so I know a lot about basic science, and I will tell you that genetics is going to be a tool. It's not going to be the answer. It's going to be a tool. It's going to be a tool to the overall thing, and it's still us in the community, the legislators, the advocators, and the professionals, both clinical and science. That teamwork is still what's going to carry the day, and nothing else really will completely. That treatment is going to be based upon all that effort. We tend to use the guidelines. There are three sets that are being used. GINA is a global initiative for asthma care, and that's a European guideline. And one of the reasons that people like that so well is that it gets updated every year. In contrast, the NIH, the National Heart, Lung, and Blood Institute, they do periodic. They haven't had a major update since 2017, but they do sort of supplements, update this part and so on. And there's increasing pressure on them to start trying to keep up with GINA. It's not to suggest that your asthma living here in Boston is different than someone's asthma living in, I don't know, Liverpool, simply because of the place you live. There are differences that are there, but it's not all that way. The treatment gets more personalized. That's the goal. Personalized is, okay, what can I identify individual? What is the pencil that's changing the owner's manual, in my little silly example from before, and how is it influenced by the environment in which I live, all the aspects of what that mean, and the personal choices that I make, both good and bad. The result of that is now this issue of reliever. Well, a reliever used to be an albuterol inhaler. It was a reliever, period, or Primatene Mist, which is not the world's best reliever, but okay. But the reliever used to be an albuterol inhaler. Well, we're changing that now. There's a thing called smart therapy. And smart therapy says I'm going to use the same combination medicine that I use as a controller if I need it for a reliever. There's a lot of upside to that. Boy, now I don't have to keep it with two. I can use one. I'm getting extra delivery of the anti-inflammatory that's supposed to be doing its job for me anyway. The downside of that is that now the payers say, oh, wait a minute, that's already expensive. Now you want me to pay for more. No, I'm not going to do it. And then you have to educate the patient and say, if your insurance company says no, you got to let us know so we can go ahead and appeal it for you, because otherwise you're going to run out of maintenance medicine and get yourself back into trouble. So the trend, again, is toward using rescue inhalers that contain both the bronchodilator and an anti-inflammatory. And the other one that's currently being evaluated, and it's on the market, is a short-term bronchodilator, essentially albuterol, with an inhaled steroid with it. Which one of those two are going to work better? I think the data, it's going to take a while to get the data to really say which one works better, but both of them are at least available. GINA guidelines update again to reminder to elicit the patient's goal for treating IE. Boy, listen to the patient. There's a novel concept. Actually listen to what the patient has to say. Listen to her concerns. Listen to her complaints. Listen to mom's fears about the kids, and then act on it. That is actually now in print. Some of us have been doing that for a long time. We're now going to get credit for it. I don't know what that's going to translate to. But they call it shared decision making. All right, give the name, whatever name, just get on with it. Listen to what your patients have to say. And that's going on, and we're teaching that in our teaching programs. And we recognize again that asthma is treated, it's sort of like a forest fire. I put out the forest fire and wait for the next one. I put out the forest fire and wait for the next one. I put out the forest fire and wait for the next one. How about before the next one, I go around and find out what is the risk to start the next fire and stop it before it starts. That is finally moving into the forefront because it has an economic basis to it. Unfortunately, the other bad thing, if there's any bad thing about living in a capitalist society, is you follow the money. And the money now is that prevention is worthwhile for them to do that. Tweaking medications to recommend various scenarios is very important, but not to the point where it's confusing to the patient. Well, doctor, you told me to do, that's where an asthma action plan is wonderful. And patients should demand and expect asthma action plans from their asthma care providers. Update about SCIT versus SLIT, well, that's a wonderful topic and discussion. It is a discussion that is growing better than it is, but nobody's to any conclusion just yet. It's really when it's appropriate rather than if it's appropriate, because in the right setting, both of them can be appropriate for our asthma patients. And then preventing occupational asthma is not new, but there's innovations being done now to actually objectify it and not immediately assume that if somebody needs to be away in their job because their job has made their asthma worse, they're just some lazy slug trying to bilk the system. If you either have occupational or have known people that do, they suffer with that a lot. That employers think that somehow it's on them, not on the environment in which they're suffering. So, poll question. Which, does that count? Does that time count against me to do the poll question? Just ask it.
I'll give you a little extra there.
Okay, see, I knew she would. She had to give me a little extra for the poll.
Poll question. How should asthma treatment be managed according to expert advice? Please pick one. That's everyone in the room and, of course, also everyone online. So we'll take just a minute for that.
Okay, the results are 91% said by stepping up or stepping down treatment as needed. And then the middle one is about 10%, and the last one's 1%. So I think right answer is A.
All right, well, there you go. Our expert advice continues to rely on more if you need it, less if you don't. And that's the trick in empowering the individual patient and their family to learn when that is. It demands regular assessment of the individual and good interaction between the provider and the patient. Again, in advocacy individuals, the smarter, the more educated the patient is about their illness. And I tell my asthma patients this all the time. I've been doing this a long time, but the person that should know more about your asthma than anyone in the world is you. And if you do that, that empowers the individual and it motivates them to want to learn as much as they can. Consensus statement, again, last fall we had a working definition that was applied for the whole idea of remission. Well, think of cancer remission, and the goal of cancer remission essentially is that I'm cancer-free. But yet people recognize that when they're cancer-free, many times there's still cancer cells in their body. It's just under control, and they don't have to take a lot of chemotherapy to get there. We're working on this in asthma. It's not there yet. There's still controversy, there's still discussion, but the goal is to get to where we can say to people, your asthma is doing so well, we can back off, and in some instances, stop your medication, you are in remission. That may happen when children get older and it lasts for years. It may happen when adults have done what they've done, they've changed their environment, they've changed something, and they're now in remission. We're trying to learn how that is so prospectively people can learn better about it. Lots of research published, safety and effectiveness for biologics, when to move and not. Telemedicine, that's particularly useful to get into areas that are difficult to access. In Mississippi, the Mississippi Delta you may have heard about, which is a very rural area up in the northwest part of the state. The poverty is incredible, 50% unemployment in some of those counties. And we're setting up a telehealth asthma clinic for them that is launching in January from the University of Mississippi. We're very excited about what the potentials for that could be. Kids and obesity, you're going to hear more about that in a little bit. The issue of COVID-19 and future viral in asthma patients become very important. For the college, just a word of 2 minutes worth of our plug for the college. This is our major journal. I was privileged to be the editor of this journal for 16 years. Love bringing it up, but it is absolutely wonderful because it can raise awareness. Many of these articles are very readable by an informed public member that's not necessarily a medical specialist. So I would encourage you to go and look at this. It's available online to look at, and then you could get information that you might be interested in from there. One in particular that's worrying is work to decrease racial disparity and promote health equity in the treatment of allergic disease that includes asthma. It's a very active process for the individuals here that are editors of this journal. Others is to promote research and education through the practice of 2 programs, an education program and a research program that brings community and academic allergists together in a partnership, to provide grant funding through the Foundation for Allergists to do very applied research in the community, and to provide more physician education and patient public information in other languages, starting with Spanish. And I emphasize that starting with Spanish, the goal is to put other languages in there as well in the future. For our members, we deliver a world-class annual scientific meeting going on right next door, develop practical resources and advocate for their patient, our patients, safety, fair payment, and access to care, and for the patients to increase public awareness, to increase awareness of our robust information in our public website and stay on top of public health and safety issues that you can find about our website, and we point you to others when it's appropriate to do so. And for our specialty to continue to work collaboratively, particularly with organizations like the AAN, to work collaboratively with other specialty groups that represent other physicians and nurses who are going to get you to the asthma specialist and to amplify our position as an advocacy. We have these 2 community-based programs that I just mentioned, and for the sake of time, we also have something called an advocacy council that we put a lot of money and effort into to legislate towards, to help them understand the importance of the things I've been telling you this morning, and they have made some significant inroads in that with our legislation in the last several years. An example is support Medicare payment reform, reduce prior authorization burdens, support physician-led team care, to invest in tracking state legislative activities, and to initiate work with other organizations on funding requests and legislations. And this is an example that is ongoing now with the CDC for full support of the National Asthma Control Program funding for 2024. These are some of the organizations that are involved, and the AAN is a part of that effort. So I would say we'll always advocate for patients to have access to allergist care and appropriate treatment. If you need more information, your allergist, they can do college.acaai.org, but for you, acaai.org will bring you a wealth of information. And with that, I thank you for your attention.
Wonderful. Thank you so much, Dr. Marshall, for kicking us off so well today. So we have time for a few questions, and we can take questions either from online, which I think Bethany is taking a look at, or in the room. I'm going to start with in the room first, and then we'll move online. Any questions in the room, raise your hand, and I'll come by with the mic.
Good morning, Dr. Marshall. I'm Charnette, and I am also an adult asthmatic, as well as a generational asthmatic. Also, my daughter has asthma, my dad, my grandpa, all those things like that. I am concerned right now as far as the cost. I was recently taken off of my Symbicort and put on Brina, which was supposed to be the generic of it and cost less, but it didn't. Now, all of my asthmatic drugs are costing me $700 a month, which is almost half of my paycheck. So can you recommend something to me in regards to getting my costs less so I can take my medications like I'm supposed to and be, the good patient?
Sorry. There's 2 approaches that I would recommend, and in fact, sadly, first of all, thanks for the question. Sadly, I have patients that would fall into your category a lot, and it is frustrating because you would be, and excuse me for using this term, but it's a functional term, you would be considered, where healthcare reimbursement is concerned, the, quote, working poor, unquote. And the argument that the concept that anything would take half of your monthly salary, no matter what it is, whether it would be housing or anything else, makes that almost unmanageable because it leaves you a little bit, such little to do anything else with. Particularly with your medication, not only quality of life, but actually life itself may be tied to that. There's 2 approaches to that I always recommend to people. Number one, make certain that whoever your primary asthma care provider is aware, completely aware of that issue with you. And the reason I say that is that, and I want to sound like I'm being self-righteous and that my group's never been guilty of this, because we have, but sort of like this squeaky wheel thing. They prescribe for you, they gave you Symbicort, a brand name, which is a nice drug, works, can be used in a SMART program and so on. But most clinicians do not pay enough attention to say, all right, what is that going to cost you? Is there a difference in pharmacy cost? Does it matter where the pharmacy is? Can you get one of these discount cards? Can you not? And so on and so forth. And if they switch to generic, the assumption that people always have, and you bring up the best point, that it ain't always true, is that it'll be much less and you'll be able to afford it. It's not 10 cents on the dollar. It's sometimes, and in some instances, it's not anything off on the dollar. It's the same cost because of the copay that you have to do. The second thing is to talk to your provider, because we have choices, and there are companies that, and again, you're in that sort of that mid-zone that is the bad thing, in that you don't have unlimited income, but you're not indigent. You're somewhere in between those two extremes. And so, but even then, these companies, now, admittedly, you almost have to have a master's degree to figure out how to fill out these things because they're so complex. But you can get a referral. We refer to social workers that are specifically designed to help individuals fill out these things to get assistance from the companies themselves. Where you can say, for example, Symbicort, I know they used to have a support company. Well, they have a line, and everyone assumes that, oh, that means I have to be essentially somebody that holds a tin can up on the corner of the street. I can't make any money. It's not true. They have different thresholds. But maybe, for example, Symbicort may be the optimal medicine for you, but maybe there's another one. And I'll just pick one as an example, Advair. It's not exactly the same, it has the same basic component and so on, but there's a program you'd qualify for where you can get Advair for free, or you could get Advair for $25 a month or something like that, which is a whole lot more affordable than $700 a month. Your healthcare provider ought to be able to help direct you toward that and give you that kind of information. So one is to help them optimize and recognize that you're being challenged financially, so they're picking and helping you with the best choice there. Not just adding one because it'd be okay to use 3 instead of 2, but maybe you only really need 2. The step up and step down is the principle. And the second is to explore these support programs that are designed for people that have real disease, they have real financial needs, and they try to meet the two. The companies use them as advertising. I don't care what they use them for, as long as the individual patient gets a benefit. That's what I'd suggest. Yeah.
Thank you. We have a question from online.
Hi. The question from online is, why do some people cough more than wheeze with asthma?
Well, we know that there is somewhere between 15 and 20% of asthma patients have what are called cough variant asthma. And if you think about the idea that cough is actually a protective response, God made your airways to have air going in and out and nothing else. And so when you get something that's in there, it could be something through your nose. That's why we're called obligate nose breathers, because our nose is so good at filtering the air. If we sit here and breathe through our mouth, after a while our brain says, why are you doing that? It may not come to your conscious level, but your brain's saying, why are you doing that? You're supposed to be breathing through your nose. So when somebody's nose is stopped up and they have asthma, after a while, their asthma is going to perceptibly get worse, whether their FEV1 goes down or not. They're going to get worse because we're designed to breathe through our nose. If anything gets anywhere near the airway, there's a little organ called an epiglottis. The epiglottis, when you swallow, flips over your trachea so that your food can go down to your esophagus and not get into your lungs. And everybody's had food that went down the wrong pipe and you start coughing like crazy. Well, let me tell you, it got nowhere near your trachea pipe. It got on this little epiglottis. So a large number of people that have asthma also have concomitant rhinitis with a lot of postnasal drainage. And that postnasal drainage can get around and tickle that epiglottis, and it can start coughing and coughing and coughing. Now, the problem with that, after a while, it gets to be a habit. Anybody that coughs for more than a couple of weeks in a row is going to develop a habit. It's called a habit cough. Sometimes it can be a continual stimulus. Sometimes it can just be the habit cough. But then what happens, it becomes a vicious cycle. If you take you'll talk about people that have exercise-associated asthma. The presumed mechanism is that they're running, they're breathing in and out, in and out, in and out, and it's cooling the airway, which creates a series of problems that results in making their asthma worse. Well, if you're coughing, you know what somebody, obviously who didn't have enough to do, did a study and published the rate of speed at which air comes out with a nice good cough. A nice, it's about 200 miles an hour. So imagine something with about 200 miles an hour coming out. If there's any kind of airway cells that are not particularly healthy or happy or anchored, out they come. Then little nerves get there and so on. We think that's part of the mechanism, part of the fundamental mechanism. So controlling cough by whatever means necessary is often very much tantamount to be able to control the asthma.
We have one more question before we head to break.
Good morning, and thank you, Dr. Marshall, for your very informative talk. My name is Leonis, and my oldest son, Anthony, had asthma attack. It's been a few years ago. He passed away from an asthma attack. And I'm a strong advocate in that area. My sister owns an educational center, and I did an educational talk there for her parents that have asthma, the kids that have asthma. And there's one particular parent that I'm thinking about. Her daughter is 3 years old and has severe asthma already. I talked to her, I've shown her how to use your inhaler, went through the whole spiel. And recently my sister called me, she was in tears, but this little baby is still having these bad symptoms. And the mom says, I didn't give her the treatment this morning because she wasn't coughing that bad. So my question is, I don't know if it's a question that can be answered, but how do you get through to people knowing that their kids or themselves have asthma, and no matter what you say, it's seemingly falling deaf ears?
Let me try to answer that briefly, because you're right. That's a topic you could talk about all day long and still not get all the answers. But and that's not uncommon. I see that as well. There's three components to me for that. Number one is a sense of trying to communicate with them in a way of showing your concern to them for their patient, their child, loved one, or themselves for that matter. Sometimes when we're passionate about something, and I'm guilty of it, I suspect many people in this room are guilty of it, our passion is not meant for anything more than transmitting our enthusiasm, but sometimes it can come over kind of heavy. It could come over kind of heavy with the idea of, you know what, if you would just do, and it particularly gets frustrating when it's someone you've told over and over and over again. Imagine us clinicians that tell the same patient the same thing every time. If we're not very, very careful, and like I said, I've been guilty of it myself. I try very hard to role model this for my fellows and residents in my clinic, because I'm influencing a lot of other people that are going to be taken care of by other providers. But it's important to remember to explore the why of that. Are they not there? Are they in denial and saying, well, you know what, if it's not there, it's sort of like being in the dark and saying, I'm not afraid, I'm not afraid, I'm not afraid. Is it, secondly, that there is a gap in their understanding, and so going back over it again is very important. And it's the third, in that what I do that I have found to be worthwhile in many instances is make limited contracts. You may not see the value in what I'm suggesting we do, but would you contract with me to do this for 2 weeks? 2 weeks. And sometimes it can be shorter than that, 2 weeks. And you say, well, and they can say, I just don't think it's going to matter. And you may be exactly right, because there's no medicine that works and no therapy that works in every single patient in every single setting. But I think this one may work well for you. Will you contract with me for 2 weeks? That if in 2 weeks you're not, and we set what the endpoint's supposed to be, I rarely set it at 100%, but clear evidence that they're getting better, because then it becomes self-sustaining, then you stop this because it's not working for you, and you call me, and then we're going to see what we do next. I've seen that one technique I've seen actually work better than many of the other ones I do. So the compassion and not letting your passion for them and their patient, loved one, not letting that come off as being somehow heavy-handed or condescending. The second is information to make sure they really do understand. And the third is to develop this limited contract with them. That combination has been very helpful for us. You're welcome.
Awesome. Thank you so much, Dr. Marshall.